Now we're going to move on to the next section, which deals with depressive disorders or mood disorders. So we're going to, yeah, Nathan, the big sad. So we're going to talk about major depressive disorder, dysthymia, bipolar disorder, cyclothymic disorder, all of the different ways that people can have depression impact their lives. So within any 12-month period, almost 10% of the population, 1 out of every 10 people, or almost 19 million American adults, suffer from a depressive illness. That is a very, very high number. But a lot of people confuse depression with just being occasionally sad. A depressive disorder is something that is persistent or it could be extreme. And it doesn't just affect the mind, it also affects the body. The symptoms of depression can manifest in some pretty oxymoronic ways. Like y'all may have heard that if you eat too much, that could be a sign of depression. But also if you don't eat enough, if you sleep too much, that could be a symptom of depression. But also if you don't sleep enough. So insomnia versus hypersomnia. Okay, so it's very opposite ends of the spectrum. It can also impact how you feel about yourself or others or your situation. Now, almost everybody is going to experience some type of mild depression in response to a situation or an external event, but being sad about something isn't a full-fledged mental health disorder. A depressive disorder is more persistent than just a passing period of sadness. It's also not a sign of personal weakness or a condition that can just be willed away. Like y'all may have heard, oh, you're depressed, just be happy. Just smile. It's like, you solved everything. Why didn't I think of that? Why didn't I just think to be happy? Or they're like, oh, you should like go outside. Absolutely not. Like going outside, exercising, all of those things. When you're going through a depressive disorder, especially a major depressive disorder, those things become impossible. Getting out of bed, showering, brushing your teeth, all of those things are huge, insurmountable tasks. So it is very much a disorder. It's not something you can just pull yourself out of. With treatment, you can make those depressive episodes much shorter and much less dangerous. Without treatment, however, that can exacerbate the condition and make the symptoms much more drastic. For instance, with suicidal ideation. Now, there are some different gender roles that impact suicidal ideation. Women tend to attempt suicide more often than men, and women are twice as likely to experience depression. However, men are more likely to die from suicide. Now, the reason for this is in the methodology. Oftentimes with suicidal ideation, it is a passing thought that is acted upon in higher rates if there is a method to complete that suicidal ideation. So if there's easy access to material that could end someone's life, that person is more likely to engage in that suicidal behavior, in that act. So people who are suicidal often follow an action plan. An action plan is put in place to help treat that suicidal ideation, which can include regulating medications, having a person in the household give out medications at the appropriate times and in the appropriate amounts, getting rid of firearms or knives or sharp objects in the house, getting rid of over-the-counter medications, making sure that they're not easily accessible. Because a lot of times suicide and attempts at suicide are spur of the moment where they see an opportunity that's presented itself, but it's a permanent solution to a very temporary problem. So not a solution at all. Now, in terms of methodology between genders, the reason there might be such a gender gap between reports of depression could be the fact that in certain cultures, there are patriarchal social constructs about emotions. In the social construct of gender, of what it means to be male or what it means to be female, it might be easier for women to report experiences of depression and sadness because they're less likely to be seen as weak. But if men report feelings of depression or sadness, then they're more likely to be seen as weak. And so patriarchal gender roles can play a factor in that. Women are more likely to turn to methods that can be more easily reversed. For instance, overdosing on medications or using sharp objects. There's a wider window for getting them help and reversing that attempt than with the preferred method of males attempting suicide, which is the use of firearms, where there's a much, much smaller window available to try and reverse that attempt. So even though more women attempt suicide, more men are likely to die from suicide. So, what are symptoms of depression? Persistent sadness, anxiety, or an empty mood. So, not just a one day you feel sad and then the next day you're fine. It has to be persistent for 2 weeks to up to 2 years, depending on which disorder. A lot of people consider when they think of depression, they think, oh, sad. So they must be crying a lot, or they're just, seem down all the time. But that's not always how depression manifests. A lot of people who go through depression also report a lack of all emotions, a lack of caring, and the inability to feel. So there's periods in a depressive episode where there's extreme sadness and the person doesn't want to feel anything. And then there's periods where they can't feel anything and they desperately want to see if they still can. Feelings of hopelessness and pessimism, guilt, worthlessness, helplessness. One of the major symptoms is a loss of interest in hobbies or activities that you used to enjoy. So if someone just stops a hobby or stops an interest, like let's say they run every day and then all of a sudden they don't run, they just sit on the couch, then that could be a symptom of depression. And part of the reason there is such a distinct loss of interest in activities or exercising or any of those things is because depression can slow you down. It hurts to move. You are extremely fatigued and extremely tired all of the time. Even your brain stops working as quickly. Depression is correlated with memory loss and difficulty concentrating. It can also impact grades. So one of the signs that teachers look out for is a student who's normally an A student, if all of a sudden they're sleeping in class and their grades take a dive. If we start seeing that, then we're like, okay, that could be a symptom of depression, because usually they're here with their grades and then there's been a drastic change downward from that. Insomnia, which is a lack of sleep versus oversleeping. So you can have on either end of the spectrum. Eating too much or not eating enough, either end of the spectrum. In major depressive disorder, which is the disorder we're going to talk about after this slide, it's not uncommon for a person going through an episode to just stay in bed and not move for days at a time. So not getting up and showering or brushing their teeth or changing their clothes or eating or drinking, like they may get up to go use the restroom and then crawl right back into bed. And that can be for over a period of 2 weeks. So very, very inhibitive to your natural functioning. Suicidal ideation or suicide attempts are symptoms of depressive disorders, restlessness, irritability, and sometimes you have physical symptoms like pain or stomach aches or headaches that don't have an actual physical cause. They have a psychological cause, but they manifest as physical symptoms. So major depressive disorder is the disorder where you have a combination of the symptoms we just discussed, at least 5 or more of the symptoms we discussed, lasting during the same 2-week period. So inability to sleep, inability to eat, loss of interest in hobbies, all of those things combined together. Now, this type of depression is much, much more extreme. It's much more obvious, but it lasts for a shorter period of time. This is a depressive episode that can be very disabling, and it can occur only once in a lifetime, but more often it's going to occur repeatedly in a lifetime. So with major depressive disorder, it's extreme depression, extreme symptoms before a shorter period of time, a few weeks, maybe a month. That's different from dysthymia, which is persistent depressive disorder. So with persistent depressive disorder, it's not extreme. You can still get out of bed and you can still do the dishes and you can still go to work, but you have a depressed mood for most of the day and for most days. So more often than not, you are depressed, you're sad or pessimistic, or you don't enjoy things. And this can be from either your own account or from other people noticing it about you. The thing with dysthymia, though, is that it's persistent for at least 2 years. So long term, kind of like if you think Eeyore from Winnie the Pooh. He's just constantly kind of sad. It's not like he's just laying there, never talking to his friends or never going on adventures, but it's like clearly he's in a bit of a mucky mood. And that's his entire character for the entire series. Like you never see him in any other way. So that would be persistent depressive disorder as opposed to major depressive disorder. One is extremely debilitating. The other one sucks, but you can still go through life and function, just if not at your peak potential. So again, differences between gender and depression. We're going to see that more women report depression and are more susceptible to depression. But again, the issues with surveys is that they can be very subjective and they can be subject to sociocultural models. So women are more likely to honestly report depression or depressive symptoms than men due to those gender roles. What's interesting here is the wide gap between the two genders. Of the men who report those depressive episodes, about twice the number of women report those episodes, with the exception of Puerto Rico. Puerto Rico is the only one where more males report that they experience depression. Taiwan must be like Disneyland or something. Like nobody's depressed there. They're like they have one person who's depressed, or one guy, one girl, and that's it. Another factor that can play a role in depression is age. So here we see more women reporting depression, and then during the age range that it's most likely to occur is before middle age. So between the ages of 12 to 25. Once you get to ages 25 to 34, it starts plateauing and then decreasing. And so many of you have probably heard, oh, these are the best years of your life when you're 16, 17, 18 years old. And you're like, okay, then I do not have high hopes for the future if this is the peak. But that sort of thing isn't true. Typically, once you get older, you have more stability, more financial security, formulated your identity, you know who you are, you know who your friends are, you may be in a career field or you may have started a family. You become very, very aware of who you are and satisfied with the way that your life is, as opposed to as a teenager, everything is so tumultuous and everything is like the most important thing that's ever happened ever. So your hormones start balancing out and your life starts getting a little bit more predictable and stable. And so that could be a factor in why rates of depression decrease, with a very interesting overlap here in the elderly population, where men actually start surpassing rates of depression in women around the age 75. So how do we explain depression through the psychological perspectives? Well, Freud would say it has to do with sex and aggression and repression. It's your unconscious. So the psychoanalytic view says that there were negative events that occurred in your childhood that you repressed memories of. And then as you become an adult, you start going through negative events that evoke those memories that you've repressed. Or you have unresolved feelings of anger or sadness in your unconscious, so you're not aware of them, that are turned inward on your own ego. So it has to do with your unconscious and repression. So the treatment for that, according to the psychoanalytic theory, would be free association. Sit on a couch and talk to a therapist until eventually you just start babbling, and then finally your subconscious comes up to the conscious level and you can resolve whatever repressed memories or feelings are there. From the biological approach, it deals medically with neurotransmitters. People with depression often have lower levels of norepinephrine and serotonin. So you're producing a low amount of serotonin, and then your neuron will pick up some of those neurotransmitters before your neurons start the process of reuptake. Now with reuptake, it's taking all those serotonin out of commission, but you haven't gotten enough registered yet. And so one treatment for depression is SSRIs, selective serotonin reuptake inhibitors. So when your brain is releasing all of those neurotransmitters like serotonin, the medication stops your neurons from reuptaking it, from taking it out of circulation. That way, the neurotransmitter of serotonin remains in your synapses for longer, which means that your neurons have more opportunity to grab that serotonin and feel happy. In terms of genetics, studies have shown that identical twins have higher rates of depression than fraternal twins, meaning if one twin has a depressive disorder, then there's a much higher chance of their identical twin having the same disorder as opposed to a fraternal twin or just another sibling. So there is a genetic link, although it's not definitive. It's not, so because this identical twin had depression, that means the other one has to have it. It's a combination of nature and nurture. In the sociocognitive model, this is defining your thoughts and society in such a way that it reflects a pessimistic view. So a depressed person tends to think internal, all right, this is my fault, therefore I need to be punished. the timeline is stable, meaning things can't change. So, what's the point in trying to change it? And that the event going on is global. This affects everything. This is the most important, or this is the only way I'm going to feel for the rest of my life. So, in the sociocognitive model, you think everything's your fault, that it's always going to be this way, and that it affects everything in your life. And that leads to learned helplessness. Why try to change if it's hopeless? So you continue in that same behavior in the same depressive episodes without getting any treatment for it. So the sociocognitive model would say you need to address the cognition, you need to address the thoughts to move them out of that pessimistic, hopeless view. Now we're going to move on to bipolar disorder. Now, a lot of people misconstrue bipolar as, oh, they're happy 1 minute and then they switch and they turn, evil or sad the next moment. That's not bipolar. Bipolar is more persistent. It may be a period of months when you're in a very deep depressive episode, followed by another period of months where you're in a manic episode. Now, people confuse that with the cyclothymic disorder. That's the quick cycling mood, where you can be different moods within the same day. But bipolar is more persistent and longer lasting. This is very complicated. Well, it's not really that complicated, but people make it complicated because oftentimes in media, bipolar is portrayed inaccurately. It's portrayed as 1 minute you're on top of the world and you're super happy and you're like talking fast and you're doing everything. And then 2 minutes later, you're in a funk. That is not how bipolar works. It is not a very sudden change. It's periods of time where you're either manic or depressed. So you could be manic for 6 months and then depressed for 6 months. You could be manic for 4 months and depressed for 3 months and then manic again for 2 months. But it's not a rapid in the same day cycle. Now, there are 2 types of bipolar disorder. So similar to how there's 2 types in diabetes. So bipolar 1 is the extreme form of bipolar. This is complete opposite ends of the emotional spectrum. You have extreme manic episodes and extreme depressive episodes. So think of extreme manic episodes being starting like 10 different projects all at once, spending all of your money, dating a bunch of different people, like all at the same time, and you're just going. Extreme mania. Okay, that doesn't necessarily mean like, oh, they're hallucinating or they're seeing or hearing things that aren't there. It's not psychosis. It's just manic behavior where you're constantly going and your frontal lobe is probably not making the best decisions because it's being inhibited. Now, the other end of bipolar 1 is extreme depressive episodes. So y'all remember when we talked about major depressive disorder where it's like for 2 weeks at a time, you're just a wet paper towel and you can't get out of bed, you can't do the dishes, you don't shower, you don't eat, that sort of depression. That's also a part of bipolar disorder 1. So both are extreme mania and extreme depression. Bipolar 2 is the less extreme form of bipolar disorder. This is when you still have extreme depression, just like in bipolar 1. However, you don't have extreme mania. Instead, you have hypomania. So your manic phases are not as severe. So you get all of the bad side without any of the quote unquote fun side from the mania. Because oftentimes people with bipolar disorder will be on their medication for a period of time because they don't want to experience the depressive end, because obviously that's terrible. But when you're in the middle of a manic episode, everything feels amazing. Your life is going right. You can do anything. You're going to start 10 new hobbies. You're going to learn 5 new languages. You're like getting along with people. You're super social. But you also make very poor judgment during that time. So you may gamble all your money away, spend all of your money, start engaging in criminal behavior, start engaging in dangerous behavior, whether in terms of drug use or sexual activity. But because the manic phase feels so good and can be so very productive, you see that sometimes bipolar people stop taking their medication. And that's going to be common across the board. People who are neurodivergent in terms of getting therapy and taking medication, oftentimes they'll get to a point where they're like, okay, I want to be off of this medication because there's such a stigma to it. A lot of people are like, I don't want pills dictating or doing anything with my body. Okay, and so they think, okay, I'm past this disorder. I've been getting therapy and I've been taking this medication. I can wean myself off of it. But some disorders will require long-term care and long-term medication. A person with schizophrenia isn't ever cured of schizophrenia. They're going to have to keep taking mood stabilizers and other treatments for the rest of their life. Same thing with bipolar disorder. It's not something that's just going to go away. You're going to have to go to therapy and get the biomedical approach for the rest of your life because those symptoms will return. So bipolar 1, extreme mania and extreme depression. Bipolar 2, extreme depression, but you have hypomania. Okay, so what are some symptoms within those manic episodes and those depressive episodes? With this, you see cycling mood changes, and it's not going to be like within the same day or even within the same week. You have an extended period of time where you are persistently manic or you are persistently depressed. And then somewhere along the line, it flips over. So mania is often going to affect your thinking and your judgment in a negative way. Your social behavior can get a little bit out of control, a little bit outside of social norms, and it can lead to some very embarrassing moments. If left untreated, some mania can result in psychosis. Now, typically, you're not going to have a psychotic break within a manic episode. It's more so if you've gone a long time without treatment, it can be exacerbated into psychosis. I don't know if any of y'all are familiar with the TV show Shameless, but one of the characters there, redheaded guy, he had bipolar disorder and he went through a manic phase that ended up in him kidnapping a baby, and saying he was going to take it to somewhere, he's going to protect the baby, something or another. Like he just straight up snatched a child and he was having a psychotic episode. So you can see how it's like in media, it portrays it as, oh, people with mental illnesses who are neurodivergent are a danger to society or they're going to commit violent crimes. Not necessarily true. Neurodivergent people are more likely to be the victims of crimes rather than the perpetrators, but that doesn't sell on TV as well. So mania, if left untreated, can lead to psychosis. Who's the guy who, Van Gogh, is supposedly one of the famous individuals with bipolar disorder. Y'all may remember that he famously cut off his own ear to give to a girl he liked. He died via suicide, and it's speculated that he was cycling through bipolar episodes throughout his life. And so that mania, like maybe like cutting off his own ear, maybe that's a symptom of a manic episode. Suicidal ideation, that definitely would fit under depressive episodes. So other symptoms of manic episodes can include abnormal elation, so feeling extremely good, extremely happy, which you may think, oh, that's not too bad, but that kind of extreme elation can lead to poor judgment. Being over talkative or overactive. So if someone is having just a stream of consciousness talking, like they're stumbling over the words, they're just talking really, really, really fast, that's a symptom of mania. Being really irritable and impatient, not needing to sleep. So you have insomnia because you're so active. Your body's just like, let's keep going and keep going, keep going. Whereas in the depressive episode, you're not going to be able to get up out of bed and you're going to sleep excessively. Grandiose notions, what this means is you develop kind of a complex where you think you can do anything, like I'm going to go gamble all of my life savings because I'm feeling lucky, or I'm going to go get into a fight at this bar because I think I'm invincible. These grandiose notions of how good you are at something or what you're capable of doing. Racing thoughts, increased sexual desire, which can lead to some problematic social behavior. Lots more energy, a part of that manic episode. Very poor judgment in terms of your frontal lobe being inhibited. Inappropriate social behavior, like in that episode of Shameless, kidnapping a baby, that's kind of frowned upon in a society. And being reckless and impulsive. But like I said before, Van Gogh is speculated to have suffered from bipolar disorder. And so there's kind of this correlation versus causation argument over whether bipolar disorder is linked to creativity. Like some famous individuals like Mark Twain, Demi Lovato, Tim Burton speculated that maybe their creativity could be a part of their manic versus depressive episodes. But again, we can't establish that causation versus correlation argument. Obviously, while in the middle of a manic episode, you're going to see a lot of productivity and a lot of creativity. But is that worth the depressive episode that you have to go through? I mean, like Van Gogh was an excellent artist, but he eventually died via suicide in the midst of a depressive episode. So those extremes need to be stabilized. So how do you treat bipolar disorder. How do you stabilize those moods? Well, the most common treatment for bipolar disorder is the biomedical approach, and it's to prevent these shifts in mood from happening in the first place. So mood stabilizers are prescribed, lithium being the most popular. So instead of going through manic or depressive episodes, you're just in the middle. So you never go to those extreme highs or those extreme lows. You're just average on the emotional scale. Now, if you are in the middle of an episode, like you're in the middle of a depressive episode, that's when you could take antidepressants to act as antagonists for your serotonin reuptake, or anxiety medication like Xanax or Valium to prevent the depressive episode from getting worse. But the thing with antidepressants is it's not just you take a pill and then all of a sudden you're happy. It can take up to 2 weeks for SSRIs to start having an impact on you. So this isn't I got an antidepressant, I'm going to take it and then I'll be happy. It's you have to continue taking it for at least 2 weeks before you start feeling the effects. Whereas anti-anxiety medications hit within like the first 30 minutes. So mood stabilizers, that's something that you're going to need to be on indefinitely to keep you at that middle level. But then if you're in the midst of a depressive episode, then you can have anti-anxiety drugs and antidepressants to pull you out of it so you can go back on the mood stabilizer. Antipsychotics are useful during the manic episodes because remember, untreated mania can lead to psychosis. So to prevent it from getting to that level, that's when you would prescribe Thorazine or haloperidol. But in addition to the biomedical approach, because not everybody is going to benefit from a one-size-fits-all approach to neurodivergent disorders, you can also combine that with therapy. So the cognitive behavioral therapy, or CBT, that can involve rational emotive therapy, where you look at the action and the belief and then the consequence of that cognition. So looking at your thoughts and addressing whether they're coherent or not coherent. So if you're like, in the middle of a manic phase, I'm going to invest all of my money in GameStop. Well, is that a logical thought or is it not a logical thought? I guess it depends on when you planned on investing it. But that's a very risky behavior. So you could be able to stop and say, okay, what is the benefit and what is the potential loss? Talking about self-actualization and your ideal versus your real self. So your ideal self may not ever go through a depressive episode, but your real self does. So you would have to maintain the use of that medication in order to get closer to your ideal self. And then psychoanalytic therapy, talking about free association, that it must have something to do with your subconscious that's triggering manic or depressive episodes. I'm leaning more towards the CBT version of therapy. Like if I were a practitioner, I wouldn't do psychoanalytic. I would probably lean more towards Albert Ellis's view of therapy, but then definitely combine that with the biomedical approach. It's not a one size fits all. Another depressive disorder that you may have heard of before is known as SAD. And I know you're like, wait, okay, so SAD is depression? Yes, because this is a specific type of depression. This is seasonal affective disorder. This is when depressive episodes hit in the fall and winter months. So seasonal episodes in terms of in the spring and the summer, your mood is fine. You're happy. But once it starts getting dark outside, once it starts getting cold outside, that's when you start seeing a distinctive shift in your mood. So it's not based on necessarily a neurochemical imbalance that's genetic. It's based on your environment. Because remember that sunlight can affect your mood and it can control things like sleep. So what is one possible cause of SAD or seasonal affective disorder? Well, the pineal gland is releasing more melatonin. That makes you feel tired. And so then you want to sleep more. And sleeping more is one of those symptoms of depression. If you try to fight the melatonin and stay awake in spite of the need to sleep, then that can make you very moody and lethargic. So people with SAD often suffer worse episodes in the winter. In fact, anybody with a depressive disorder, whether it's depression or bipolar disorder or SAD, suffers worse symptoms in the winter than in the summer because of the effect of light on our psyche. So we have all of the usual symptoms of depression in this disorder. You're eating too much, sleeping too much, weight gain, particularly during the fall and the winter. However, in the spring and the summer, everything goes back to normal. You're no longer depressed, full remission. In order to get diagnosed with SAD, it has to be something that's persistent, not necessarily you're sad all the time, all year, but in the past 2 years, you have seasonal depression, but then when it's not fall and winter, you're perfectly fine. And your seasonal episodes have to outnumber the non seasonal depression. Because if it's not related to the seasons, then it could just be persistent depressive disorder or a major depressive disorder. So they have to be able to differentiate between which one. Because even light therapy can be used to treat seasonal affective disorder. I'm sure y'all have seen like the lamps that they sell after anything blows up on Twitter. They're always like linking lamps underneath the viral tweet. There's like, you need this to help you wake up in the morning. It's like, okay, fine. If I see another post about this dang lamp, I may buy it. That's how they get you. And so that can be a method to treat SAD, or being on antidepressants during the fall and the winter months. So not necessarily being consistent with it throughout the entire year, but simply using it when these seasonal episodes occur.